Yeah, great. Okay. This is one of my favorite grand rounds of the year, the day we get to present the Kaler Award. I'd just like to say a few things about Grace Marie Kaler, who is memorialized with the award that we are giving today. Ms. Kaler spent the majority of her career working at UW Medicine. She worked in laboratories on research and also training trainees in research methods. She worked initially in the nephrology division. She worked with the famous Dr. Scribner, for whom the Scribner shunt is named. Also worked in hematology and environmental and occupational health sciences. She was cared for here at UW Medical Center during the last days of her life in a way that impressed her family deeply. And she left a bequest, a substantial bequest, to the cardiology division. And we actually have never really figured out why it was the cardiology division, but at some point she must have been impressed with what we do here in UW Cardiology. When we received the bequest several years ago, we discussed how to use it, and a bequest like that would generate a certain amount of income each year, and we decided to use it to award a presentation given at our weekly research conference, which at that time was both fellows and faculty. It's now a faculty research conference. And I'd just like to read a little bit about the goal of that conference and put in a plug for all of you to attend it more frequently. So the primary goal of the conference is to provide division researchers with a forum for sharing their research results with colleagues and receiving constructive criticism that helps them improve their research. The Grace Marie Kaler Cardiology Research Endowment Award will be given to one research conference presenter per year whose work is judged by her or his colleagues to be particularly meritorious. The past awardees, I recognized at least one of them in the room when I looked around. Andrew Chang, David Owens, Nana Sotadania, Francis Kim, Farid, Musabi Harami, Alexis Beatty, Todd Dardis, and this year Jim Kirkpatrick, who's going to give a presentation on sexuality and intimacy in patients with LVADs and their partners, uncovering the undiscussed facts. And I must say that we decided to give Jim this award because we were particularly impressed with his ability to move his project forward, present his data clearly, and interpret it insightfully. He's joined in his presentation today by Jason Bjelkengren, who's a nurse manager in our advanced heart failure, cardiac transplant, and mechanical circulatory support unit. So, Jim, we're looking forward to your presentation.
Thank you very much, David. I appreciate that introduction, and realized that when I woke up this morning that I actually had a respiratory infection. I was fine yesterday, but that explains my deep and husky voice this morning. So I want to thank also the Grace Marie Kaler family for this wonderful contribution. They made an additional contribution, and that is homemade baked goods outside, if you haven't partaken of them yet. They continue giving to this institution. We're deeply grateful. And I also want to thank the Locke Foundation, which is funding this work, and Dr. Dichek and the Division of Cardiology. We don't have any financial disclosures with industry or other entities which may compromise this presentation, but we do want to sort of cast this in a larger framework, and to do so I'd like to quote one eminent American philosopher, Donald Rumsfeld, not usually known for philosophical pronouncements. However, he did actually make this profound and incredibly confusing statement. There are known knowns, there are things that we know. There are known unknowns, that is to say, there are things that we now know we don't know. But there are also unknown unknowns. There are things that we do not know we don't know. So now everything's crystal clear for everyone, and we can move on to our outline. And what we are trying to do here really is to uncover the facts so that they can be known. So the first thing that we're going to do is basically talk a little bit about what we know and we don't know about this topic, which I tell you is a lot in the latter case. Then we're going to talk about what we actually uncovered with this study. And then we're going to move on and discuss what we may need to do about it, but this is very preliminary and pilot work, so you need to take the discussion of the implications with some grains of salt. And then finally, we will discuss what we don't yet know, but know that we need to know, a la Donald Rumsfeld, and that will be the future work that we're hoping to use Kaler research funding to promote. Now you may be asking, why are we talking about this in cardiology grand rounds? And that is a very good question. This is not something that we normally discuss in cardiology, but I will tell you that at least from the fount of all knowledge, Google search, there are 9.8 million hits dealing with this issue of sex and cardiovascular disease. This is a big deal, and for the most part, we ignore it. In patients with heart disease, the research and data suggests that quality of life, psychological health, and relational satisfaction are all very much affected. And this is something that we need to be concerned about. Now, this is a great review paper looking primarily at heart failure patients, but it also dictates and demonstrates some of the other issues that really all of us deal with when we're dealing with patients with cardiovascular disease. We all deal with patients with these morbidities and risk factors, which are risk factors not only for sexual dysfunction but also cardiovascular disease. And there's these physiologic factors and processes that actually affect both of the disease states. Heart failure symptoms, as we'll see, actually play a major role in affecting both sexual function and also patients' quality of life from a cardiac standpoint. Now, obviously, lifestyle affects both of them. Age is a factor. And then both devices, the ones that we're going to talk about today, but then there's a substantial literature also on ICDs, medical treatments that we give, most notoriously beta blockers, but also hydrochlorothiazide, some other medicines, and then of course the psychological factors, which are very prominent in both sexual dysfunction and also in heart failure and other cardiovascular diseases. Now, why did I personally get interested in this? And that's probably an even better question. As you may know, in addition to using cardiac ultrasound to diagnose things in the echo lab, I have been involved with cardiac palliative care and cardio ethics for quite some time. And a study that we did a way back was actually targeting caregivers and patients with left ventricular assist devices. And two papers that came out of that were very revealing. We did not specifically ask about sexual dysfunction in this. We didn't think to ask about it, which I guess tells us something about this topic. But we found that a number of patients and caregivers actually thought this was kind of interesting. You know, really spontaneously, as we're talking about quality of life, female caregivers said things like, well, it's been difficult losing my independence. As I said, I have no social life. Other people commenting on this, social life decrements actually were talking about feeling like they'd fallen off the edge of the earth. Can't do that because we are going to appointments all the time. I'm having to go to do this or that for him, get something else for him. It's very difficult from a social isolation standpoint caring for VAD patients. He doesn't do anything or go anywhere with me anymore. So socially it's changed a lot. And then, of course, sex post-LVAD came up as well. Our interviewer asked, and is there anything that was missing from the presentation of what having an LVAD would do for you and your husband's lives? And the female caregiver said, it was funny because I remember her husband said, well, what about sex? You know, we're young. And the provider was like, well, sometimes you got to learn new positions, different things, and be creative. And then this final quote, I have no sexual life and we were had a very active sex life. Well, that just got turned off. And you do miss things like that, physically and emotionally. And then this is my favorite quote of all, because we actually interviewed the providers as well about issues related to caregiver stress. And in reference to the post-LVAD state, this provider said, sex is a big deal. Now with that, I'm going to turn it over to Jason for the next part of our presentation to give a little bit more background about this whole topic and also explain kind of where we are with LVADs.
Good morning, everyone. So my experience for this research has kind of grown out of personal experience. I started my career in nursing in 1997 and quickly got into the transplant and ventricular assist device space, and actually this subject kind of approached me rather than me approaching this subject. After patients would leave the office, they would close the door and say, "Could you talk to me for a minute? I've got questions about things that the doctor didn't talk to me about." And those questions were usually centered around intimacy and sexuality. We're really good at putting all of our quantitative data into databases and tracking things like hemolysis and surgical outcomes. The INTERMAX registry is a very robust database for this particular patient population, and we've seen over the years that these numbers of implants have just grown exponentially. So as far as that kind of data, we have a lot of numbers we can look at and analyze, and it's really ventricular assist devices that become the mainstay for treating advanced heart failure refractory to medical therapy. That being said, as the volumes increase, are we really addressing the needs of the patients? And so this topic is something that really focuses on quality of life. So we've seen an increase from just the last 10 years threefold as far as implants. The numbers worldwide are continuing to grow every year, and we're seeing huge increases in our destination therapy population, which is basically, it's a bridge to the end of one's life. So how did we get here? Really, as we've seen our industry changes with technology, every year we see something new coming out. There's a lot of work on the bench that has made these devices evolve over time. When I started my career, we would have patients basically have a refrigerator that they pushed down the hallway that had about a 30-minute battery. So their quality of life was about a 30-minute walk to visit neighbors in the hospital. And now we're at the point where, as you can see from this, very good visual, that these devices have shrunk in size, they've become more portable, and we are now having to deal with patients for years and even a decade into their implant, whereas before we just basically took care of them at the bedside with tubes and intubated and waiting for that heart transplant to come along. And so I think as we've seen survival increase and our outcomes improve, we've needed to address more of the issues that the patients are concerned about rather than what we as providers and caregivers are trying to do, which is just to keep patients alive. And so now we have, just here at UWMC, we're caring for about 80 patients in the WAMI region who have these ventricular assist devices. And that number has gotten up over 100, and at some programs nationwide it's in the hundreds, and internationally it's in the thousands. So as we see a growth in this particular patient population, we're having to dig a little deeper into these more quality issues. We do a lot of measuring of quality of life with things like 6-minute walk tests and asking people about how their activities of daily living. But to go a level deeper is to get into these more personal issues, which are very important to patients. And so what an LVAD used to be is basically, as I referenced, just in the hospital, not really planning to go anywhere, so the topics of intimacy weren't even thought of or addressed. And over time, we with the clinical improvements and technological improvements, we've seen patients become ambulatory and patients actually discharging from the hospital. And so as the devices became more portable and more wearable, we as clinicians have had to keep up with that. And I think that's why we're at where we're at today with our talk specifically on intimacy and sexuality, is because this is something that's really important to all humans, and it's something that needs some attention. And so we've really downsized the technology to the point that it can be worn very comfortably on people's midsection on either a belt or some sort of a holster. We have at least 3 devices that we implant here that our patients are dischargeable to home, and we didn't include total artificial heart, but it's also a biventricular device that we are able to discharge people home on a Freedom driver. So again, we're talking about replacing someone's heart with an artificial pump and then being able to discharge them to the community, something we would have thought unforeseeable as few as 3 decades ago. So what do we use these VADs for? There really are multiple indications for the use. We have patients that are not able to come off of bypass, or issues with large heart attacks. We refer to things like bridge to transplant, or destination therapy, or bridge to recovery, or decision. This slide is kind of just a tongue-in-cheek. Back in the 80s, when the West Seattle Bridge, there was a bridge that basically didn't go anywhere. And during that era, there was a lot of people moving from California buying property, and I think the flavor and feeling of the Seattle community was, it wouldn't be a bad idea for people from California to just take that bridge. But you know, the culture's changed, and with that change, of course, now Seattle is much more welcome to everyone, and everyone gets to take the bridge that doesn't go into nowhere. But for this particular patient population, the destination therapy is really the biggest growth nationally and internationally, are people who are actually living the rest of their life with these devices. And so we feel that as we advance, we need to keep up with the growing technology. We need to keep up with the psychosocial needs of our patients. So what are our patients doing when they have these devices? Well, our patients are riding bicycles, and they're even riding horses, and actually they're driving. We clear them to drive, and this was, unthinkable. And really, we wonder that if they're able to do this, what more should we be doing? How much can we push the envelope? From the Intermax registry, we really don't have a lot of information about the psychosocial components of people's lives, and so as far as collecting data and having more research on this topic, it's something that both Dr. Kirkpatrick and I want to advance, and respectfully be able to have all clinicians be able to have the same level of knowledge and support to our patients with cardiovascular disease requiring these devices.
So thank you very much, Jason. An excellent overview of ventricular assist devices and the issues and the lack of data that we're all facing. So that brings us to what we know, but maybe we also don't know. And I love this quote by Isaac Newton: "What we know is a drop, and what we don't know is an ocean." Unfortunately, even after this presentation, that's still going to be true. So there are 7 million people in the U.S. with heart failure, 500,000 new annual cases, and 50% 5-year mortality. Unfortunately, that hasn't changed a whole lot despite all of the different things that we do, and of course it's incredibly costly. And in the setting of all of this, huge percentages of heart failure patients report sexual dysfunction. Even over half of younger patients report this. It's not just all in the old patients. Now, why is this? Well, in part, it's because sexual activity can actually be fairly taxing on the cardiovascular system. It has been estimated to cost between 3 and 4 metabolic equivalents, which is basically the same as climbing 3 flights of stairs or doing general housework, not the housework that I do certainly, but other people, and gardening, and I never do gardening, so I can't speak to that. But it clearly raises the heart rate, the right ventricular systolic pressure, the PA diastolic pressure, and other parameters. And heart failure patients actually feel this as an impact of both physical and psychological burden on their sexual function. Dyspnea, fatigue, poor circulation, anxiety, all these things can contribute to sexual dysfunction. Decreased frequency, lower satisfaction, and loss of interest are all well documented. And this was a very interesting study that basically compared heart failure patients to baseline healthy controls in terms of their satisfaction, both with partners and without partners. And they noted that, of course, heart failure patients have less satisfaction, but they also had less satisfaction compared to the time before they had heart failure. There are associations in the literature. Men are more likely to report this, but nonetheless 25% of women report this, which is still a substantial issue. Beta blockers, as with many other things, have been reported, although the physiology may not support it necessarily. And clearly depression and anxiety, which we mentioned are common in the heart failure population, are also common associates with erectile dysfunction and other things. And so we get this sort of unfortunate cycle here in which we have depression, anxiety, that leads to relational dysfunction via sexual dysfunction, and then depression and anxiety results, and we get this unfortunate cycle which repeats itself. There's a very recent study which actually looked at this, reported again that men were more likely to report sexual dysfunction by quite a bit, but when women had it, it was equally bothersome on quality of life rating scales. And just to go back to our initial diagram here, you see all these things that can affect sexual function and cause sexual problems in heart failure. And if we think about the impact of ventricular assist device on them, there's a number of different areas. So one is that there's a negative effect. You actually have a physical device with a drive line and battery packs and a controller, and this probably gets in the way, to be perfectly honest. But there are other things that would make one think that perhaps there's improvements. So certainly some of the physiologic factors are improved by ventricular assist devices, which are restoring to some extent cardiac circulation. Heart failure symptoms we know are improved, and many of these patients are put on sildenafil, not for erectile dysfunction, but to lower the pressures in their pulmonary arteries. Maybe there's a spillover effect with erectile dysfunction. What about partners? Remember, this is what got me into this to begin with. We know from the literature that male partners of patients with heart failure have challenges to their self-image, and of course are a little bit more reticent in sexual activity because they view their female partners at least as being more fragile. We don't know that information about same-sex situations. For women, they feel loss and uncertainty, and these are definitely effects. And again, there's not been as much data on this as on the patients. This is a very interesting study coming from this institution a few years back. It was an interview study of partners' experience of living with heart failure, and they demonstrated there were substantial concerns about social isolation. This is about the only thing that I could find related to intimacy and social isolation in the heart failure room. There probably is more out there, but I just wasn't able to identify it. And I do want to highlight the work of Cindy Doherty from here, who was on this position paper from the European Heart Journal, which really did a very nice job of going through issues related to sexual counseling in patients with all cardiovascular disease, and I would really recommend for those who are interested to read this paper. But one of the things that they put in there is that sexual activity may be reasonable after LVAD, but of course there's no real evidence. This is level of evidence C. Now, there has been some studies that looked at this. Way back in 2004, Ralph Petrucci, who's a really excellent neuropsychology researcher, looked at this issue in a number of patients, and they found that actually post-LVAD, and this was the old HeartMate 1 LVAD, they found same or improved social life, and 50% had, quote-unquote, improved attitude about sexuality post-LVAD. There was concern about damaging the device. There was one person who was concerned that the LVAD actually made him sterile. And there were no adverse effects with sildenafil. These are all good questions. Now, unfortunately, there were only 8 patients. There were no females, and nobody was over 60. These are all bridge to transplant HeartMate 1 patients. A more recent study from 2011 demonstrated that LVAD patients had improved sexual experience compared to pre-VAD. Partners were worried about the devices, and they had to make a number of adjustments in things like barriers or binders, batteries, controllers, different positions, that sort of thing. And there was an increase that they noticed in non-sexual intimacy. Again, very small numbers, and there were only 2 females represented. Then finally, a more recent study from 2014 had a comparison between LVAD patients and heart transplant patients, and what they demonstrated, and this was work done in Israel, is that while 50% of LVAD patients had no sexual activity after the placement of their LVAD compared to 6% of patients after heart transplant, a larger percentage of them reported that there were minor and significant problems when they did engage in it, but still there was a substantial number who apparently had no problem at all. Again, rather small numbers, only 11 patients with the HeartMate 2 and 3 with the HeartWare, and only 2 females. So we identified these gaps in the medical literature. The numbers are small from what we know. Partners really, for the most part, haven't been studied all that well. Women definitely have not been studied that well. The elderly have been underrepresented. And then we really don't have much data on clinician knowledge and comfort about this. So one of the main questions that we were asking is, post-implant, do patients and their partners experience improved or decreased or no change in intimacy, social life, and sexual function? And the reason that we were considering this is not only because of the literature I just showed you, but just we need to account for the fact that there are fears. So fears of equipment fracture, malfunction, other problems, hurting the patients, and then of course the fear of social situations that people don't want to go out because they have these LVADs. Loss of libido and feeling distant can happen because you have this implanted device. And then we really had no idea what the effect of the LVAD is on erectile function. Theoretically, you're getting more blood flow, but it's continuous blood flow. The pump just goes continuously. It's not pulsatile the way the normal cardiac circulation is. And of course, all these patients are on beta blockers. Now, they were before the LVAD, and they just continue to be so. On the other hand, as we've stated, these patients have improved energy now. They have improved quality of life. It's been well documented. Improved blood flow, as we noted. There may be this sense that now there's a safety net, so maybe it's safer to engage in sexual activity after an LVAD is in. And many of them are on sildenafil, which reduces pulmonary vascular resistance and has our other well-known effects. So what did we actually uncover in our study? This is Jason in a former life, of course. This is a pilot study, so take that everything with a grain of salt. But using our UW Mechanical Circulatory Support Program patient list, we identified patients and their partners. We excluded everybody who'd had a recent LVAD implant within 3 months. We figured that they weren't really thinking about sexuality at that point. They had to be adults and English speaking. And we employed, with the help of our consultants from both OBGYN and urology, these scales, which are apparently quite commonly used. One is the Revised Female Sexual Distress Scale, which has 13 different questions on it, and there's a Likert style of scoring. And then for the men, we used the International Index of Erectile Dysfunction questionnaire, and this is a 15-item questionnaire. And basically, it divides the question and the results into different functional domains, from erectile dysfunction, orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction. None of these have been validated in VAD patients, of course. Pre-implant sexual involvement was another area that we thought we needed to investigate because this is an important co-founder. If you weren't active before, then measuring how active you are afterwards is actually going to be influenced by that. We also wanted to find out about whether or not sexuality, intimacy, and social life had been discussed with patients by clinicians pre-implant. And we were interested in whether sexuality, intimacy, and social life was better, same, or worse after LVAD implant for both patients and partners. And then we went back to the medical record and got medications, obviously important co-founders, and any history of genitourinary procedures or disorders. So here's our demographics. We had 64 patients and 17 partners. Of course, not everyone answered all of the questions, as tends to happen here. Very few female patients, as is consistent with LVAD implants across the world. They tend not to get the type of heart failure that can be treated with LVADs. And unfortunately, very few partners, the majority of whom were female. This is all very consistent with other literature, but we were quite disappointed that more partners didn't participate. You can see the education breakdown here. It's quite wide. And then our racial breakdown, the Caucasians were definitely well represented. This is Seattle after all, but we had a fair percentage of African Americans as well. Here's the data on sexuality. Interestingly, in the 12 months before VAD went in, 42 of the 64 patients were sexually active, and 10 of the partners reported that. And then we asked them, if you hadn't been, when was the last time? And a lot of them, it had been quite a while since they'd engaged in sexual activity. And then since the VAD went in, this number dropped, 66% down to 42% reported sexual activity. Partners didn't change a whole lot. And then when we asked them how has sexuality been affected, the majority actually said, or the plurality said, that it had been unchanged for the most part, but you will notice that there were more people saying that it got worse than saying that it got better. And then when we asked patients, was this actually discussed in the pre-implant, there's a lot of discussion that goes on pre-implant, and was this one of the topics? The vast majority said no, it was not. And then we said, well, if it had not, do you wish it had been? And 43% of them said that they wish that it had been. Of the partners, the same thing. Most of the time they reported it hadn't been discussed, and a larger percentage said that they wish that it had been. When we looked at fears of on the patient's perspective, fears the partner hurting you or the fears of the equipment breaking, we found that most people actually were not worried about this, but there were some numbers that were concerned about that. Among the partners, the same sort of thing, but again, a larger percentage of them were afraid of hurting the patient. When we looked at our actual scoring systems here, we had a mean of, for the women's score of 10.5 with a pretty wide standard deviation. And basically, if you look at what that means, these people were just under the discriminating cutoff for actually having sexual dysfunction. Very small numbers, so take that with a grain of salt. For the men, in our different domains here are the numbers. The erectile score actually ended up falling in between. It actually was lower than controls, but right in between where the people with established erectile function actually would land. The rest of them were actually quite a bit lower than on the other scales than the controls and about near where the patients would be. Again, relatively small numbers. If we just take the men who are sexually active after VAD, which is a substantially smaller number, we actually found that, not surprisingly, all of these numbers were better for them because obviously if you're not engaging in it, you're probably going to, there may be reasons why you're not, and that may have to do with erectile dysfunction. But again, it sort of falls in between the controls and patients, at least from what we know of prior work. We wanted to find out among the group that was sexually active if there were any sort of associations, and we didn't find anything terribly statistically significant, but we found some trends that these devices that are smaller and fit up right against the heart, both the HeartMate or the HeartWare device and also the HeartMate 3 device, the men reported that were more likely to report higher, therefore better scores if they had these devices compared to the HeartMate 2 device, which is implanted below the diaphragm and is a sort of a larger device. And a lot of this was driven by erectile function. Not sure exactly how that works. These devices do have different modes of activity, but they're all continuous flow, and it may have to do with the size. So again, something that we'll have to investigate further. We also found a trend towards improved sexual function in the patients who had sildenafil use afterwards, the 12 of them that had it in their medical record. And again, this, not surprisingly, probably had something to do with the erectile function. When we looked at intimacy and social life, a larger percentage of partners reported feeling distant after the LVAD was placed than patients. And intimacy actually was unchanged for most, but again, it worsened, was more likely to worsen than to improve, particularly for the partners. And then when we asked about if they had avoided social gatherings after the LVAD, we found that about a third of both patients and partners reported that had actually happened. Most said that their social life had been relatively unchanged, but again, more of them noted that it had worsened than had improved. When we asked about intimacy, if it was discussed pre-VAD, again, the patients said no, it had not been for the most part. Interestingly, it appears that social life was discussed, at least in half of the cases. And when we asked those for whom it had not been discussed, which it had been, 40% said they would have liked intimacy to have been discussed, and 30% said they would have liked social life to have been discussed. When we asked the same question of partners, it looks like intimacy was discussed a little bit more frequently with the partners, again, some very small numbers. Social life actually had not been. And when we asked the partners if you wished that intimacy had been discussed beforehand, 64% wished that it had. And when we asked the same about social life, 55%. There was no association with feelings of distance or avoiding social situations or effect on social life and intimacy that were associated with whether or not it was discussed pre-VAD. So here's some quotes that we got. We got some good things and maybe some ambivalent things and then some actual bad things. So intimacy, one person said, this dependency has made us both more aware of our love for each other. We're not having problems before, but we're significantly closer. Another person sort of reflecting the ambivalence, having my husband change my driveline dressings weekly was tough. I've been very creative at not letting him see my belly, which I thought was an attractive pre-VAD. Total love and trust prevails. They were able to get past that. In regards to social life, the VAD units enabled me to be very active, not just around water. That's a good thing. I am no longer limited to staying at home. On the other hand, another patient said, a lot of people don't really invite me out since I had the VAD placed. I really sit at home with my kids. People are scared, period, because I have a VAD. And then on sex, erectile dysfunction's gotten worse due to my wife concerned about damaging my VAD equipment or hurting me. Can't do as much positions. The baggage gets in the way and reminds me of the VAD. My wife thinks she's going to cause me a heart attack. My device is always in the way. The gear is so omnipresent that I feel imposed upon physically. And on intimacy, fortunately, this couple said our intimacy level after the VAD surgery is more of a closer physical than sexual. On social life, we're encouraged with the improvement in his health and social life. He never goes anywhere at all. He stays home on the couch all day while I stay in my room by myself. And when I do feel the need to get out, I'm always alone. And partners on sex, I do get nervous about hurting him. Beyond that, we still have fun. It's been the same, but not the same positions. The device has a tendency to get in the way or the battery cords aren't long enough. We are huge cuddlers, hugs, and thoroughly enjoy that, but would be nice sometime down the road to have a deeper intimacy though. The machine makes it hard to feel comfortable at times, but not overall affected. And then the negative effects on the partners. Non-existent sexuality. I believe mainly because he's depressed and feels inadequate. Always on your mind, where's the VAD cords, etc. The few times we've attempted to have sex, it was so quick he couldn't finish. I don't understand why. So here's our summary. Patients were less likely to be sexually active after VAD than pre-VAD. Partners, not so much, but small numbers. While almost half reported no change, more reported worsening than reported improvement. Sex was not discussed pre-VAD for the most part, and 43% of patients and 69% of partners wish it had been. Most are afraid of being or causing hurt or equipment, but partners, or most are not afraid of that, but partners are more afraid than patients. And then these interesting trends, perhaps HeartMate 2 may be worse for males and driven by erectile dysfunction. Sildenafil may actually ameliorate it. From intimacy social life perspective, a quarter of patients, a third of partners felt distant after the LVAD. Intimacy was unchanged in most, however. Improved was about the same as worsened. For a third of the patients and partners, they avoided social gatherings, and social life was unchanged in most. However, it worsened more likely than improved, or larger numbers worsened than improved. Intimacy and social life, again, was not discussed by clinicians pre-VAD for the most part, and almost half of patients reported that social life was discussed, however. And similar to sex, more partners than patients wish those social life and intimacy had been discussed pre-VAD. Now, there are a lot of limitations. This was a single center, a small study. We had very poor partner enrollment, unfortunately. Some of this is due to the fact that patients did not have partners, but we also had some trouble recruiting partners. Clearly there's recall bias, and patients who are going to participate may be more likely to recall favorably or very unfavorably. Psychological profile, we did no psychological testing in this, just looked at depression and anxiety in their medical histories, and we really have no data really on the actual physiological impact, especially in relation to erectile dysfunction. But nonetheless, we thought that there might be a few things that we need to think about doing that might be implications from this study. And I would again refer you to this very interesting and well-written document that Cindy Doherty contributed to on sexual counseling for patients with cardiovascular disease and their partners, which I thought was a very important connection. And they identified, and this is for all patients with cardiovascular disease, a number of barriers to having these discussions happen. There's the assumption that patients are not interested or are not active. Well, we know from our data that is certainly not the case. There may be a lot of provider inexperience or provider uncomfortability in discussing these issues. I would count myself in that category, not a comfortable thing to discuss in the office visit. There's a lack of training about how to bring these things up. There are time constraints. They could take a long time. Cultural background issues may play a role. This is more appropriate to discuss in some cultures than others. But we can't let stereotypes get in the way of that. Overprotection issues and embarrassment also play the part in both the patients and the providers' perspectives. But one of the great quotes from this paper was, the opportunity to have a detailed discussion with medical staff was perceived as the most important aspect for resuming sexual activity without risk. Provision of sexual instructions and sexual therapy were also related to the resumption of sexual activity. Now, these are in patients who just had coronary artery bypass grafting, but I think this is probably true across the board. If you don't talk about it, the chance of resuming normal sexual activity is a lot less. They also quote this way to kind of conceive of the issue and bring it up. So first of all, you may want to actually ask permission. You say something like, it's common for people with heart disease to experience sexual difficulties. I'm going to ask you some questions about it if that's okay. Then provide some limited information, perhaps in response to this question, questions that they ask. Like, for instance, how hard is it on my heart to actually perform sex? You can answer that question, 3 to 5 METs. Then you might want to provide some specific suggestions that are related to their disease process. And then for some patients, intensive therapy, referral to a sex therapist or a trained counselor may be necessary. They also note that there's a better form of doing this, and this is the mnemonic here. Bring up the topic, explain your concerns, tell patients you can help, timing. You may want to postpone the discussion till after they're out of the hospital. Educate them, and then record and document your discussion and your recommendations. Sexual counseling can take many different forms, but essentially you can think about it in several different ways. One is providing of information, assessing actually what's going on. As we saw in the male's standard form there's erectile dysfunction, there's orgasmic problems, there's psychosocial issues and overall satisfaction. You provide support, and then there's that specific advice component. And then, of course, in some patients, if they're not already on sildenafil, pharmacotherapy may be appropriate. Cardiac rehab may be the best place to make this happen, and this actually is a component. I was talking to Alexis yesterday about this. She mentioned that this is brought up in a lot of cardiac rehab situations. In Ireland, they're actually doing a trial called the CHARMS trial, I guess after Lucky Charms, that is a pilot study looking at specific sexual counseling intervention. And essentially what they're going to do is train and support the staff, and they're going to institute staff-led patient interventions, provide information booklets, and then put a bunch of awareness-raising posters around the cardiac rehab. So let's come back to Donald Rumsfeld. There are things that we still need to know, and we know some of them, we don't know others of them. What we still think we need to know about this is the impact of the specific sexual dysfunction components on quality of life. We did not really investigate this fully, and of course you need more numbers to investigate this better. The impact of anxiety, depression, the device type, again a trend in our study, needs more data. Impact of beta blockers and sildenafil. And then the patient characteristics correlated with actual dysfunction or other problems. And this includes standard demographics as well as same-sex couples and everything else that we just don't have data on. There's also a very interesting thing, again, with such a low number of partners, we weren't able to investigate this, but patient-partner discrepancies and non-congruence. If one person said, hey, everything's great, and then the partner says, actually, that's not the case. We didn't want to actually do a dyadic interview at this point in this initial study because it does get complicated and people may not want to do that. There's also a need for more explorations about the connections between intimacy, sexual function, quality of life, and social isolation, which actually appear to be correlated. Maybe the same people who are having all three problems, but they did tend to cluster in that effect. And then this big question about when do you bring this up? When is the appropriate time? There's a lot of things going on pre-implant. Are they just going to forget about this, or is this an important component of informed consent? And so essentially we want to be like Bill Gates and say that we're making I don't know into I don't know yet, and that we will find out. And part of what we want to do next is a longitudinal study. We want to investigate what clinicians think about this, and then eventually getting to interventional studies with development of education programs and materials that cover bringing the topic up and discussing it, the issues of non-sexual intimacy, and then also this whole issue of mechanics. And we're very fortunate that Cindy Doherty has done work with patients in the ICD realm in regards to safe sex with ICDs and the actual mechanics. Now, I was talking to Greg Roth yesterday, and he actually brought up a very important point that we're going to have to consider. Now, you remember that we had patients, but not a lot of partners, and some of that was because patients didn't have partners. Well, there are social gatherings for patients with VADs, so it is possible that two VAD patients may meet each other. And I'm not aware that this has actually happened. Perhaps Jason knows of this, but that may introduce a level of complexity that we need to actually think about. So again, we're going to hopefully look in this next study at patient partner, patient caregiver, dyads, and congruence, and talk to the clinicians about it. And then also do this longitudinal assessment. Look at what's going on pre-VAD as sort of part of an informed consent, and then sample patients at 1, 3, 6, and perhaps even 1 year, 12 months, looking for changes over time, because we don't know about that. And again, we don't know when is the best time to address these issues. We need to address sexual and non-sexual intimacy, as well as social isolation. Depression and anxiety assessments should be part of this, as well as quality of life measures. And again, what we want to do eventually is develop some interventions that can actually be helpful. Because we don't want the rise of the machines to create this problem, in which the VAD comes between this lovely couple taken from the internet, who are actually together. This guy has a VAD, he's wearing his pack right there. What we would really like is actually to think about this more in the sense of enhancement. And for some people, that's what will happen. They will, in a sense, become the bionic couple. They will be able to do things that they had not previously been able to do. And that is hopefully what VADs can actually do for people. The bigger picture also, and put this in a larger context, because not only do we have many other types of devices and machines which may go into that, but Jason is involved with an ACC initiative here, which is actually looking at Pinnacle data collection. The Pinnacle is basically a registry of sorts, which collects a lot of data from individual cardiovascular practices. And there's a big push in the ACC right now to look at this for quality improvement for institutions and practices. So right now, from an advanced care planning perspective, they are developing a toolkit, and they're trying to find ways to integrate this with the existing electronic health record, provide resources and referrals for these clinicians who participate in Pinnacle, and then really develop kind of a shared mental model about these things. Advanced directives need to be assessed, and what we would maybe eventually add to that is sexual function also needs to be addressed in an appropriate way. So our take-home points from the talk: number one, post-VAD, sex is a big deal. Intimacy and sexual dysfunction are significant issues for patients after LVAD and their partners. Clinicians should play a role in uncovering these facts, and there may be some interventions which are going to be particularly helpful. Certainly we'll want to tailor the approach to the individual patient and the patient's device, review their medications and what could be contributing to sexual dysfunction, address depression and anxiety, and for the third time I'm referring you to this excellent paper that Cindy participated in. So we want to thank the mechanical circulatory support team here who does all this great work. Everything that we said, I think about this and things not being discussed is true everywhere. It is not just here, and actually we may be much better at this than other places. Cindy Doherty obviously has had a major role, as I've said. I want to thank Stephanie Cooper, Clifford Moore, Sharon White, and then our consultants from OBGYN and Urology, Edith Chang and Thomas Walsh. ITHS actually did all this data collection in the cardiology clinic, and Chuck actually provided the stats for us. And again, I want to give a lot of thanks to Grace Marie Kaler's family, not only for the wonderful baked goods this morning, but also the promotion of research at the University of Washington and the division, the Locke Foundation, and Dr. Dechek. And also, in the words of someone who's somewhat infamous for their sexuality, I want to thank all of you. Thank you very much. Wayne.
So I think this supports our perception. We heard enormous amounts with the HeartMate 1 about improved sexual function with Type 12. And even though we didn't do a study like this, I'm sure your results would have been dramatically different with the HeartMate 1, because even though that had a huge tube coming out, it was noisy and all those things, we had spontaneous reports of multiple people. And with the current ones, we don't have the same type of response, and now we have some data to suggest that that's true. On your HeartMate 2 versus the other ones, you probably need to compare the bridge to transplant because the HeartMate 2s only improved with destination therapy. So I imagine age and other things may play a factor in there that might remove the differences between. But great presentation.
Yeah, it's a very good point. So just to repeat for those watching in the comfort of their homes and elsewhere, Wayne brought up the great point that similar to Ralph Petrucci's study earlier, the HeartMate 1 patients were spontaneously reporting improvements in sexual function with this pulsatile flow. And once we switched to the continuous flow, which is a more durable platform, we were unable to see those, at least anecdotally, the same improvements. We don't have HeartMate 1 data, unfortunately. There really aren't too many of those patients around anymore, but a very interesting idea about the pulsatility of flow. The HeartMate 3 device has a minimal amount of pulsatility, probably not enough to make any difference, but with larger numbers, maybe that has some kind of effect.
We have a lot that we've transplanted, and you might go back retrospectively and ask them the same type of questions before with their LVAD and after their transplant, and it might give you some information.
So that's an excellent point. Perhaps a retrospective study in the patients who had HeartMate once been transplanted would be very good. And I do want to address this issue too of patients who are destination therapy versus bridge to transplant. Very important. It may be younger patients and patients who have that light at the end of the tunnel with a transplant who have sort of better mental and sexual health at that point because of their situation, as opposed to those who are stuck with the device the rest of their lives. Thanks very much. Excellent points. Yes?
Yeah, I'd like to say my experience with this, working with Bruce, way back in 1938, there was a pathologist who published an article on healing of the myocardial infarction. And after that, most of the post-MI patients were sitting in hospitals for at least 2 weeks with healing because that was thought the time to take healing. And so there was a fellow by the name of Birch who was saying that this was never necessary. It took almost 2 decades to change that philosophy. And I worked with Bob Bruce doing blood pressure during showering every day. It was thought exercise was not good. And so there was a lot of animosity at the time. You had to rest the heart. So I'm so happy to see that this has come such a long way over the decades. It's wonderful.
That's an excellent point. The perspective post-MI, people were supposed to rest back in the day for up to months at a time. Eisenhower was in the hospital for I don't know how many months after his heart attack. But now we realize exercise is good for the heart. And perhaps another interesting question, perhaps sexuality is as well. Any other questions? Yes, Cindy.
When I wondered, I didn't see on this slide if you had something about the variable control income, the time of implant until you did your questionnaire for patients. And then the second question is, if you think about why there was such a small number of partners that participated, was it your data collection strategy, or do you think they just were not interested in providing that type of information?
So I'll take the second point first. Why do we have so few partners? Was it a problem with our data collection, or whether they're not interested? I don't know for sure. I suspect it's the former. I think going to the cardiology clinic, we assume most of the time that the partners would be accompanying the patients. That turned out not to be the case. We did have an option to fill it out, the questionnaire out online, and we gave the patients that information, but people, when they go home, they haven't been convinced that they should do the study in person. They're not really going to do it online afterwards. So we need to find better ways to actually address that. The first question, dealing with the time since implant, we tried to get everybody after the 3-month period, and we have a fairly wide variety within that. I don't think our numbers are going to be big enough to give. I don't remember if I asked Chuck to run that, but to really give any sort of sense if the time since implant, if people get better over time. But as you told me, we needed to do in the next study is really this longitudinal investigation investigation to see where people are at and if there are actually changes over time with the patients. And I'm certainly hoping we can do that next. Kevin.
Jim, that was a perfect talk, and thanks for once again showing that transplant's a better operation.
Yes, so add one more on there.
I'm curious what your strategies might be for getting larger samples going forward.
Yeah.
Clearly, powers the channel.
Yeah, absolutely. And we have thought about a multi-center study. Our caregiver stress study involved 6 different sites that we were able to do phone interviews with patients and providers, and we still didn't get all that many people in there. We're somewhat limited in the depth of questions that we could ask. Despite the fact that VADs have grown exponentially over time, there's still not huge numbers of them that sort of, if 20% of people are actually going to respond to this, we're probably not going to have large numbers for a while. But we need to think about options to do this. I think this is probably an exciting enough topic that we might get buy-in from other centers, but it is also a sensitive topic, and there are people who are not going to want to discuss it. And maybe that's another thing we need to investigate, is why is it that people don't want to discuss this, and what are the actual numbers in which people don't feel comfortable doing this. Greg.
Does the UW offer sexuality counseling? Is there a resource that's reimbursable that you can refer patients to if you don't have the time or that?
That is a good question. I don't know. Jason, do you know if we... I will say that one of the things on my to-do list is to sit down with Mark Sullivan, who is actually from psychiatry and embedded in the clinic, and could provide at least some of the initial assessments in ways that we're not there. The other point to make is that palliative care providers actually probably have a much better sense of how to engage in these sorts of conversations than we do. And Stephanie, you've been helping us with this project too, but what is your sense sort of about how these things can be provided for patients?
I doubt that there's counseling, sexual counseling that can be done. I think that's usually a pay out of pocket type counseling. Other psychosocial counseling. What we did, what Charlie and I did in the clinic was develop a list of outside providers who'd be interested in providing not sexual counseling, but just general psychosocial counseling for patients with LVADs. And I think a resource like that would probably be the most useful. Unfortunately, the patient would have to either have money or have an insurance carrier that would be willing to pay for it, and that I don't know.
So a really important point to make, that most of the time this is out of pocket and we have to refer outside the institution. But Stephanie's done great work in setting up opportunities for that. But what that probably means is that it's all going to land on us to actually investigate these issues and educate ourselves more about it.
There's one other cue from the Rumsfeld quote of the unknown unknowns. That actually comes from a late 50s psychology methodology called the Johari window, which is a methodology for looking at group therapy, readiness to change, and perception of others. And the 4 windows are based on knowns, unknowns, and the unknown unknowns. So that gives the extension that dyadic interviewing may be used.
Yes, excellent point. Dyadic interviewing should be done, and I guess I'm not terribly surprised that Donald Rumsfeld was plagiarizing someone on that. And anyway.
Or it suggests he was in therapy.
Or he was in therapy and he knew this. It's also possible, but...
Last question, Kate.
To prove Kevin's point, you should re-interview these people after their transplant.
Yes.
The same partners and the same questionnaires to see if it's improved with transplant.
That's a very good point. We'll add that to the list.
I'd like to thank Kim and Jason for this, and we'll give a small token, and we'll get you one to Jason. And again, I'd like to thank the Kaler family for sponsoring. Thank you.